My name is Craig Hofmeister. I'm a myeloma clinician at Ohio State, and I'm very happy to be here today. I am going to talk, so what you just had was a very excitable man who talked with you about very many things. And as a suffix to him, I am going to try to provide a more calm, slow going, and you're going to get some of the same topics again, but from a different angle. He was awesome. He shared with me some of his slides, so I kind of knew what he was going to talk about. So the points of repetition are by intention, and I'm hoping that you come away with, oh, okay, I get it now. Now it's making sense. Get it from another perspective, and my hope is it'll be helpful. So myeloma genomics is the topic of my brief 25 minutes with you. So the things on the left really are the topics, and I like to make it a little simpler and try to think about why are genomics important, and the question there is more about what kind of cancer, what kind of myeloma do I have? And in Columbus, we're a little simpler. We don't have that many different kinds of myeloma. It's either easy to treat or hard to treat. And that's how I simplify it. And that's the type of myeloma you have. I will never tell my patients exactly their genetics. We won't talk about, clonal heterogeneity. What we talk about is the bottom line. Is it hard to treat or is it easy to treat? We're going to talk a little bit here about some chromosomal translocations. We'll talk about plasma cell leukemia because there's sometimes a quick question about what does that mean, and do I have leukemia or do I have myeloma, or why can't you guys get a naming system that makes sense? We're going to talk a little bit about clonal heterogeneity, and I just have one slide on this. This is something that's been a lot in the news in the last 2 or 3 years, and it deserves one comment to you today. And ultimately, we're going to talk about some targeted approaches for myeloma. So we are also agreed early on, he is called the other Craig, and I'm the Craig. So the other Craig talked about risk very quickly and control. These seem simple and obvious to myeloma physicians because we talk about this all the time, and they're not that simple. So risk involves how likely it is the myeloma cell will die in response to treatment. So low-risk patients have easy-to-treat disease. Chemotherapy is more likely to kill the myeloma cells. Let's bring the other Craig back. And these patients have a longer overall survival on average. Patients with high-risk disease have more chemotherapy-resistant myeloma cells, and treatment is less likely to work, and these patients will require closer monitoring, more drugs in their combination, and this is what leads to success in treating these patients. Risk is very different from control. The status of your myeloma is how well it's controlled, and it has nothing to do with risk. The status of your myeloma is you're either controlled or you're not controlled. A little bit like risk. Easy to treat, hard to treat. Control is relevant, and it describes, in essence, how many myeloma cells are in your body and how many myeloma cells were in your body yesterday. So on the left-hand side, you have a myeloma patient who's in good control. There are no new myeloma cells being made per unit time. And as you head along to the right, you have a progressive loss of control. And so patients who have no new myeloma cells, well, they're not going to develop kidney failure. They're not going to have worsening anemia. They're not going to develop fractures. But as you lose control, and as these termites become more active in the patient's skeleton, they can chew up the bone and put the patients at risk for fracture. They can make more antibodies, increasing your risk for kidney failure, and they can fill up the bone marrow, causing increased likelihood the patient will be anemic. So you can have high-risk myeloma that's in excellent control, or you can have low-risk myeloma that is completely causing the patient significant symptoms with fractures, anemia, and kidney failure. Okay, he also went over this topic, and it bears repeating. There are 3 ways to look at the status of a patient's myeloma, whether it's in control or not. You can do a blood test looking at your serum protein electrophoresis, and that measures your monoclonal protein, which is one way to look at the status of your myeloma. Number 2 is that you can look at your serum free light chains. This is also a blood test, and it looks at a different part of the antibody. It is more sensitive and less reliable than the monoclonal protein. It is a different test. And the third thing is a 24-hour urine, which I very seldom use in my myeloma patients anymore. The first 2 rows are the most commonly used tests to assess the status of your myeloma. So, many patients in myeloma can have a period of time where their myeloma is under good control, but is beginning to so-called wake up. So on this graph, over horizontal axis is time, vertical axis is whatever measure you want that is most sensitive and reliable to indicate the status of your myeloma. Could be your monoclonal protein, could be your kappa light chains, could even be your 24-hour urine protein electrophoresis, but that's pretty rare now. So it's usually your monoclonal or one of your light chains. And over time, if this curve starts heading up, this is when patients are waking up on the left-hand side, and on the right-hand side, they have symptoms. The most common question I get from patients is, well, when do I have to start treatment? What level do we start treatment? Does my IgA have to get to 1,000, 1,500? Does my monoclonal have to get to 600? 800? Do my light chains have to go 200? None of those things are relevant. It's really the slope of this curve that is more relevant. Hence, my favorite patients are engineers and accountants, because they love graphing their monoclonals and their light chains. They look at this and I say, the slope, well, obviously you need to get treated when the slope of the curve changes, to which 90% of my patients say, what's a slope? And I was like, rise over run, man. But this is what it is. So over here, this is when you want to think about treatment, because this is the time that you have symptoms. Now, this patient is put this way because this patient in general has low-risk myeloma, meaning they're more likely to be sensitive to chemotherapy, and they're also more likely to have a prolonged wake-up period. Patients with, and in essence, the time for a good clinical trial is when, before they develop symptoms, before your back is against the wall and you have to have a response. But you don't want to treat them during your first year when you can detect things, but the patient's asymptomatic. In patients with high-risk myeloma, that period of time is much shorter. So you have much less flexibility. So you can't follow these patients necessarily the same way. Patients with high-risk myeloma relapse more quickly, they develop symptoms, and the myeloma is harder to treat. So there's much less flexibility. So knowing whether you're low risk or high risk is very helpful. The easy way to know whether you're low risk or high risk that's not that sensitive, but it's easy to get, is when you're initially diagnosed, before you've received any treatment. 2 tests are performed: beta-2 microglobulin and albumin. The tests just roll off the tongue, don't they? And you can see that if your beta-2 microglobulin is low on the top row, these patients have more sensitive disease. And on the bottom, beta-2 microglobulin higher, these patients have more chemotherapy-resistant disease. This was published a really long time ago, based on patients treated an even longer time ago. So ignore the columns on the right. This does not suggest the survivals that are accurate or indicative of what is expected today. But what this talks about and reflects the biology of the myeloma, that is still accurate. A high beta-2 microglobulin before the treatment is always a bad thing. Now, you'll notice that that's just blood tests, and that's only part of the game. That is a very insensitive measure of risk, of how aggressive or how hard to treat the patient's myeloma is. Really, we want to add in the genetics, a little bit more information about these myeloma cells to complement the blood test obtained prior to treatment. So we developed a revised international staging system, which is slightly more complicated. And you can see the beta-2 microglobulin is still there. You can see it down there at stage 3, so the criteria is there. But now we add in primarily some genetics. And we use terminology that's very difficult for normal people to understand. We'll think of most of you, except those in the front row on the right-hand side, as normal people. And this is hard for you to understand because no one speaks like this normally. So you're going to see these acronyms, and since you're already here, you've probably gone on the internet, looked at the myeloma, these acronyms will come up a bunch. So NODEL17P is code word for the short arm of the 17th chromosome in your myeloma cells, but not your normal cells, is missing. And this suggests that you have higher risk myeloma. Those T414, 1416, that's when part of the 14th, 4th, and 14th chromosome got together when they shouldn't be getting together. And same with the 14th and 16th. These create proteins in the myeloma cells, giving them tools to fight chemotherapy more than patients with low-risk disease. And hence, the presence of any one of these changes pushes a patient to more higher risk myeloma, more chemotherapy resistance, and thus a shorter survival. So primarily, these are obtained by doing either a karyotype, which we honestly don't do at OSU anymore. You get newly diagnosed myeloma, we don't do a karyotype because it's so often negative and so often useless that why do it? And a karyotype is a lot because you're essentially putting myeloma cells in a dish and expecting them to reproduce. And myeloma cells are just like my in-laws. They're absolutely incapable of being in a foreign environment, reproducing, being fertile, and going on and flourishing. They need to have their separate, special environment that they've created in order to survive and do well. So myeloma cells are just like my in-laws. They're not going to survive in a dish. And in general, what you do is put some myeloma cells immediately after a bone marrow biopsy and stain them for specific mutations which describe high-risk disease. The ones that we look at patients with a deletion of the short arm of chromosome 1, the short arm of chromosome 17. These translocations, people who are getting together who should not get together, and how many of us know people who have gotten together who should not be together. And lastly, a 414 translocation with a number of other things that increase this patient's sensitivity to, or decrease the patient's sensitivity to treatment. We often like to say that if you have a FISH or a karyotype that are both normal and you're newly diagnosed, they didn't have any myeloma cells to test. One or both of these tests are going to be abnormal in a newly diagnosed patient virtually every last time. And if it's not abnormal, they didn't have any myeloma cells to test. All right, so this slide, just take a deep breath. It's going to be okay. This slide is complicated, but it's worth spending a little bit of time because I want you to see what I see. And when I see newly diagnosed myeloma patients, I look at risk and I look at the patient. What type of myeloma do they have and what type of patient is in front of me? So on the right-hand side, you can see the recommendations for treatment in the fit. And on the far right-hand side is treatment in the unfit. Fitness is one of the 3 things that most describe how long a patient is going to live. How bad is the myeloma? How bad are the other medical illnesses? And how fit is the patient? These 3 things describe how long you're going to live, and they're equally important. And apparently fitness, I shouldn't talk about. Never mind about the fitness. Okay, it's better than I got. Okay, so on the top row is my view of those patients with high-risk myeloma or chemotherapy-resistant myeloma. And you can see all the genetics there, etc. These patients, I try to give as many drugs effectively as possible over the longest period of time. On average, myeloma patients who receive effective therapy live longer. And the more they receive effective therapy, the longer they live. So these patients usually have 3-drug induction, transplant, and 3-drug continued therapy. This is a lot of treatment. And not every patient can do this. Those patients who are unfit cannot move on to transplant and generally get 3-drug therapy until it doesn't work anymore, and then ideally new or novel treatments after that. For patients with standard risk disease, no one thing is better than the other. And let's face it, standard risk disease is in general 60% of the patients that we see. So they can get 2-drug therapy, 3-drug therapy, transplant. They can get lenalidomide maintenance if they are minimal residual disease positive after transplant. And those patients who cannot go on to transplant usually receive 2-drug treatment with Revlimid and dexamethasone. It is very rare that we use melphalan-prednisone ever, but we have occasionally used it. I just saw a patient who had cirrhosis and also has myeloma. And the treating oncologist felt that melphalan and prednisone was appropriate. Low-risk patients are few also and far between, but these patients sometimes can receive initial therapy, transplant, and no further therapy, and just so-called watchful waiting. And usually these patients get 2-drug induction if they are unfit. This is my way to treat most myeloma patients that I see. What is plasma cell leukemia? Okay, this is a terrible thing that we've named this. I don't know why we named it this way. It causes such confusion. So, what type of myeloma do you have? That's one of my key things. Do you have easy to treat, intermediate, or hard to treat? What's the status of your myeloma? Is it controlled, waking up, or uncontrolled? And the last thing I ask in a small proportion of myeloma patients is, where is your myeloma? Is it in the marrow? Does it involve your bones? Is it chewing at your bones, causing holes in your bones and increasing your risk of fracture? Is it in your blood? Is it slippery so that they can slip out of the bone marrow and head into your blood? These patients are at increased, I'm so sorry if I keep talking about things I'm not supposed to, but if these myeloma cells are slippery and head into your blood, that means that they are already relatively chemotherapy resistant. Because they're so slippery, they tend to be able to travel. They are less like my in-laws, and they can go and flourish wherever the heck they want to. This is more aggressive. And in fact, if there's 20% or more of these things, we call it plasma cell leukemia. All that means is that it's hard to treat myeloma, and it happens to have a large number of myeloma cells in the blood. Say again? How do you determine? Great question. So on average, you do a blood test at a reasonable medical center, and they're going to do a CBC. Probably all myeloma patients here have had a CBC, a complete blood count. White cells, red cells, platelets. On the white cells, they should do a differential, and they should obviously see the myeloma cells percolating along in your blood. That's how it should happen. Does it always happen that way? No. A lot of times people do differentials and they just look and they say, oh, there's some granulocytes, lymphocytes, and whatever, monocytes, something or other. Sometimes they miss the fact, wait a minute, these are all myeloma cells circulating in the blood. It's disturbing how often that is missed. Clonal heterogeneity and evolution. This sounds really complicated, but it's something most of you knew walking in here, but we made a big deal of it when we discovered it because somebody could publish about it. So at the beginning, on the left-hand side, you see a myeloma patient from when they didn't have myeloma cells. This is nice. Wow. Okay, so didn't have myeloma cells. More myeloma cells, lots of myeloma cells. Now the colors really describe the different tribes that you have in myeloma. And at the time of diagnosis, and this is the time of diagnosis, right here, there are 2 to 6 tribes of myeloma in the average patient. Different genetics, different response to drugs, basically somewhat different diseases. And this is all under the cover of the same IgG lambda that you have as your monoclonal protein. So that monoclonal protein is made up of output from 2 to 6 different tribes of myeloma cells. So what happens? Patient gets chemotherapy and boom, there's a lot less myeloma cells. But there are still a number of tribes there. And at the time of relapse, which is what it is at the far right, usually one clone predominates. It doesn't mean that the other clones aren't there. Some of them aren't. And their new ones can develop. But on average, at the time of relapse, one clone really takes over and is really responsible for the vast majority of the monoclonal protein or light chains secreted. This is called clonal heterogeneity. It's relevant because most of you already knew this, and most of you already knew that some of your myeloma cells are responsive to some treatment and some of your myeloma cells are not.